Several methods are now available for providing nutritional supports in patients with nutritional deficiencies. If the GI tract is not functional, total parenteral nutrition via a central or peripheral vein can be done. A specially designed nasogastric feeding tubes may be used in patients who need short-term nutritional support. Several tubes are available in the market presently. They are all silastic tubes, 8 French in size with heavy mercury tip. They are easy to pass and they are easy on the patients. However, they are only good for short-term use because of frequent problems, including frequent clogging, falling out in patients who are often restless, and difficulty with providing nutrients without constant drip of nutrients. It's difficult also to send these patients either to home or to the nursing homes with nasogastric tubes. Gastrostomy should be considered in patients with neuromuscular or transitional dysphagia who are subject to frequent aspiration pneumonitis and malnutrition. These patients often have lack of coordination of the swallowing muscles, and once they are asked to liquids and or solids, they'll aspirate. There is very little that one can do for this group of patients medically, except to improve their nutrition and to prevent their aspiration pneumonitis, which, however, conventional gastrostomies often require general anesthesia and laparotomy in this group of patients who are often poor risk. The purpose of this presentation today is to show you an endoscopic method of constructing a gastrostomy tube for feeding purposes, which does not require general anesthesia or laparotomy. Our patient today is an elderly gentleman with amyotrophic lateral sclerosis who has lost 60 pounds in the past year or so and has been admitted 3 times to the hospital with aspiration pneumonitis and from chronic bronchitis because of aspiration. This is a modified method that was recently developed by Dr. Guayas and Ponsky at Case Western University. The tube consists of a number 16 mushroom or wing catheter with the flared end cut off and then forced into the wide end of a number 16 Medicot cannula with the help of a suture. The suture coming out of the cannula is also used to tie to the thread coming out of the patient's mouth. This provides a taper tip catheter assembly system through the gastric and abdominal wall with minimal amount of trauma. This is the end of the catheter was originally cut off, and we are using it as an inner retainer or bumper. Another piece of catheter also has been cut off, beginning as an outer anchor, which will be sutured to the abdominal wall. This patient has been previously prepared with xylocon spray of oral pharynx and intravenous and Valium. First, a fiber optic gastroscope is passed into his esophagus in the left lateral position. The esophagus is visualized. There is no organic lesion causing obstruction. There is no evidence of esophagus. The stomach is then entered. At this point, we roll the patient on his back, and the stomach is inflated with room air. A point is selected 2/3 between the umbilicus and mid-left costal margin, as indicated here. The upper abdomen is then prepared in a sterile fashion. The abdominal wall is then transilluminated to ensure the closeness of the gastric with the abdominal wall, and for the point of selection of catheter insertion. The point of entry is anesthetized with the local anesthetics down to the fascia. A 5 mm incision is made with a number 11 scalpel blade through the skin and fascia. A number 16 Medicot catheter is thrust into the stomach via the incision and proper positioning of the catheter is ensured. Visualization. The needle is then removed, and a number 20 silk, a 60-inch silk thread is introduced into the stomach via the catheter. This is then grasped once it reaches the stomach with an alligator forceps. Silk suture and a scope is both removed to the patient's mouth. Previously prepared mushroom catheter is then tied to the silk which is exiting from the patient's mouth. This is lubricated. And then it's introduced into the stomach in a retrograde fashion via the mouth, esophagus, and the stomach. The catheter end is then grasped with a grasping forceps and pulled out steadily through the gastric and abdominal wall. The scope is then reintroduced into the stomach in order to ensure proper positioning of the catheter in the stomach. The outer bumper is then slipped over the catheter against the abdominal wall. The position of catheter is fine. Now we take picture of the catheter as it looks inside the stomach. The scope is then removed. After securing the catheter to the abdominal wall, a luer lock adapter is passed through the end of the catheter, so the patient can be started within 24 hours on some supplemental feeding via his gastrostomy. Our patient today will be sent home, and he will be seen tomorrow again as an outpatient before he is started on his tube feedings. My colleague Dr. Joseph Parado and I have performed 21 endoscopic feeding gastrostomies in the last 8 months on patients with neuromuscular dysphagia. Majority of these patients have had pseudobulbar palsy due to multiple CVAs, coma, amyotrophic lateral sclerosis, multiple sclerosis, Eaton-Lambert syndrome, and severe polymyositis, among other patients that we've performed EFG on them. We've had no morbidity or mortality related to the procedure. No patient has been readmitted to the hospital with aspiration pneumonitis. All patients have gained weight. In summary, the procedure is safe, it is simple, it takes an average of 10 to 15 minutes to complete the procedure, and it is cost effective. All patients who need long-term nutritional support, especially those with neuromuscular dysphagia, should be considered for endoscopic feeding gastrostomy.